Hi, I'm Hyacinth, and I'll be presenting with my system mate Lily. I'm really excited to be presenting at the first Plural Conference. Our collective is the Sapphic Bouquet. We have 6 members, and we are quadgenic. We don't have any degrees, but we have years of experience related to being a system, and I've also read many academic articles about clinical forms of plurality. My goal for this presentation is to explore a plural positive understanding of dissociation. I'll also discuss whether or not dissociation is always pathological. Our system believes that DID and OSDD fall under the umbrella of plurality. Now, some of you may disagree with this, and that's fine, but that's the position we're coming from. We believe that headmates within DID systems are sapient, sentient people, and that they have the right to decide whether or not their system chooses final fusion or cooperation. Another goal for this presentation is to explore whether dissociation is always a maladaptive coping mechanism, since that is the title of this presentation. We're also going to talk about how it relates to the treatment of plural systems who are diagnosed with DID. Now, one important thing to know is that not all traumagenic systems have DID, and some endogenic systems may have experienced trauma. Some endogenic systems may even have DID. When we're talking about traumagenic and endogenic, we're talking about individual beliefs about system origins. So, when I talk about DID or OSDD systems, I'm not implying that they're traumagenic. That may be what medical professionals believe, but it is not what we believe. We believe in the right for systems to interpret their own beliefs about their origins. That being said, let's start with a question that seems simple, but really isn't when you start digging. What is dissociation? So, dissociation is when a person's mind disconnects from their sense of self, their body, or even their memory. Psychologists generally agree that dissociation is a separation of the parts of a person's mind. In some cases, this can cause a sense of identity alteration. Pierre Janet coined the word dissociation. Janet believed that dissociation was not a coping mechanism, but an illness brought on by stress, which is a much different view than the way in which psychologists understand dissociation today. Dissociation is currently believed to be a coping mechanism for surviving extremely stressful events. Dissociation can also be a fairly common experience for some people. Take, for instance, trance states, meditation, zoning out while driving. These are all dissociative experiences. But sometimes people experience dissociation regularly, which can impair their memory and their ability to function. Impairment is generally what defines a dissociative disorder. One type of dissociation is a separation of mind from body, which can manifest as derealization, which is the experience of feeling that the world itself is fake or that nothing is real, hence derealization. The second way that this can occur is depersonalization, the feeling that you are not in your body or that the version of you reflected in the mirror is not you. Really though, these are just arbitrary categories which describe people's experiences. Both depersonalization and derealization are usually considered to be dissociative disorders though. The third type of dissociation is a form of amnesia or fugue. Amnesia is a loss of some memories relating to a specific period of time. A dissociative fugue means a person loses all their memories of who they are. Quite often they will disappear, not knowing where they live or knowing people they previously knew. They can also wander and become lost. Usually they eventually recover their memories. Dissociation is a very broad term. Many psychologists have conflicting and contrasting understandings of dissociation. So when I'm talking about dissociation, it's important to know that there are many different experiences. Dissociation itself is just an arbitrary category, given to a very diverse set of experiences. Dissociation becomes disordered, unhealthy, or maladaptive when it is distressing, or when it impairs a person's ability to perform simple tasks. Because of this, maladaptive dissociation is believed to be harmful. It's also typically viewed as a leftover coping mechanism from a traumatic event. In the context of clinical or disordered plurality, DID is a dissociative disorder believed to be caused by traumatic events during a person's childhood, making DID a leftover coping mechanism. This is echoed in texts such as the ISSTD treatment guidelines for DID. The International Society for the Study of Trauma and Dissociation is generally recognized as authoritative, especially when it comes to dissociative and traumatic disorders. Their view is that dissociative identity disorder is a maladaptive coping mechanism. Here in their guidelines, they quote Putnam, a DID specialist and researcher. Quote, "Dissociation is a normal process that is initially used defensively by an individual to handle traumatic experiences that evolves over time into a maladaptive or pathological process." Unquote. Academic views on DID are further clarified by this quote from the ISSTD. Quote, "Although the DID patient has the subjective experience of having separate identities, it is important for clinicians to keep in mind that the patient is not a collection of separate people sharing the same body. In the service of gradual integration, the therapist may, at times, acknowledge that the patient experiences the alternate identities as if they were separate." End quote. To professionals, headmates are not people. In many academic papers, we are called dissociative self-states, or another similarly dehumanizing term. We are not real to them. Some professionals treat headmates as real for the purposes of therapy. To each other, and to our plural communities, we're real. We aren't just leftover maladaptive dissociative coping mechanisms. Speaking within clinical terminology and understanding, dissociation can cause what's known as identity alteration, which leads to the formation of alternate identities. Identity alteration is an effect of dissociation believed to be caused by mental barriers and memory compartmentalization. This causes the person to view themselves as different people at different times. Unfortunately, this model presupposes that alters are parts of one person. I don't find this convincing, since our system doesn't have any memory loss and amnesia. And yet, we're still all distinct people, each with our own preferences and ways of existing. The professional beliefs about maladaptive dissociation get applied to all plural systems, DID diagnosed or not. The way we understand plurality is that some systems have DID. You don't become plural from therapy, and you definitely don't become plural exclusively from trauma. Otherwise, endogenic systems wouldn't exist. But professionals who specialize in treating DID and OSDD don't typically see endogenic or non-trauma systems. And there are a good number of endogenic systems who exist and are never studied by DID professionals. This makes healthy systems invisible. DID professionals are only concerned with studying disorders and treating them, and as a result, most therapists and DID researchers can't grasp the idea that plurality exists outside of DID. All of this leads professionals to believe that being a singlet is healthier than being plural, since being plural to them is automatically a maladaptive coping mechanism. Professionals also tend to assume that being a singlet is the default or normal state for a human being. These assumptions are based on the social values and norms of society, not scientific research. To a DID specialist, singlets are normal, and plural systems are not. Instead, we are assumed to be damaged, broken, or abnormal, trauma being the assumed cause of this damage. These beliefs can cause a significant loop of stigmatization, When Singlets do research into plurality, they focus on systems that have DID. Systems that are able to function just fine are completely ignored. Many, if not most of us, are hiding in plain sight. If headmates are assumed to be dissociative self-states, having been caused by trauma, then the treatment must be to remove the dissociative coping mechanism, namely headmates or alters. The ideal treatment goal for most professionals is to fully integrate these disparate self-states into one person. Cooperation is merely a step towards this goal. Dr. Kluft, a prominent DID researcher, explains that, quote, "I encourage the alters communication and teamwork, all of which is in the service of eroding narcissistic investments in uniqueness and separateness and promoting integration." Kluft, 1993. Kluft also states that, quote, "It is most important to decline to engage in arguments over integration with the patient, because this course of action almost inevitably heightens narcissistic investment in the wish to avoid integration, and introduces an adversarial tension in an already difficult treatment. My personal style is to encourage a wait-and-see attitude. Usually by the time integration becomes an issue, it is in the process of occurring and perceived as inevitable. The argument is then irrelevant." Kluft, 1993. To psychologists, both cooperation and final fusion of headmates are integration. Integration being the exact opposite of dissociation. Within that framework, plurality is an unhealthy coping mechanism that needs to be treated. Psychologists don't typically specify the difference between integration of memories and senses and integration of identity. Something to notice is that Kluft's position is coercive. It doesn't encourage informed consent to treatment, which is a breach of the Hippocratic Oath. It's also a breach of doctor-client trust. It's readily apparent that DID specialists do this quite often, especially when you read academic papers about DID. Speaking of academic papers about DID, let's talk a little bit about the efficacy of final fusion, since most professionals strongly recommend final fusion as the ideal treatment. The studies that do exist about final fusion are not promising. Kuhn's 1986 states that only 25% of 18 DID patients had fully integrated, meaning that they no longer had headmates as the result of final fusion during therapy. 2 of those 5 patients redissociated, meaning that the integration failed. More notably, all of the 18 patients had achieved co-consciousness during the course of therapy, suggesting that co-consciousness may be a more useful and attainable goal than a final fusion of all headmates. In 2017, a 6-year follow-up study co-authored by 5 researchers, Merrick, Weberman, Lowenstein, Lanius, Putnam, and Brand, stated that only 12.8% of approximately 189 patients achieved final integration of headmates. No mention of cooperation or co-consciousness. Faking fusion is one factor that was not considered in either of these studies. Some DID systems may fake integration in order to escape psychiatric abuse. As you can see, treating headmates as though they are a maladaptive coping mechanism is not working in practice. For some systems, final fusion may not be possible, nor beneficial to their overall functioning. As I've discussed, dissociation is typically defined by the clinical perspective, and not on the experiences of systems. There is a distinct conflict between a plural positive perspective and the clinical perspective, which makes it necessary for me to discuss switching. Most of you already know what switching is, but I'll define it very briefly. Switching in is what happens when one headmate enters front, or you could say they gain control of their shared body. Switching out is when one headmate leaves front and another headmate gains control. Within clinical literature, switching is commonly believed to be a type of identity alteration caused by dissociation. Each alter or headmate is a specific dissociative identity, having its own thoughts, memories, and reactions. Thus, dissociation is labeled by professionals as synonymous with switching, as if defining the word dissociation wasn't confusing enough. It only gets worse, though. Since researchers and professionals can't seem to conceptualize plural experiences in any other way than as a form of dissociation. This is based on the idea that dissociation is a maladaptive coping mechanism. Clinically speaking, can we measure dissociation empirically? Enter the Dissociative Experiences Scale. The DES is a commonly used tool that professionals use to determine how often a person or system is dissociating. A score is given which determines whether that person's dissociation is pathological. The DES was created as a research tool, but is used in clinical settings to assess dissociation. The questions involve common experiences of dissociation, hence, Dissociative Experiences Scale. The clinician asks, how often do you experience this? The answers range from 0% of the time to 100% of the time. Answers are scored by adding all of the results together and then dividing by 28, which is the number of questions in the DES. 4 points is the average result for people who do not have a dissociative disorder, 7 points for people with agoraphobia, 20 for people with schizophrenia, 31 for post-traumatic stress disorder, and 57 for dissociative identity disorder. We took the DES and scored 42 points. We fall somewhere between PTSD and DID. It's interesting that we answered some of these questions with the highest possible number. They were highly relatable, and we almost always experience these things. These particularly relatable questions touch on common experiences that plural systems have. We'll read them out to you. Maybe you can relate. Question 7. Some people sometimes have the experience of feeling as though they are standing next to themselves or watching themselves do something, and they actually see themselves as though they were looking at another person. Question 18. Some people sometimes find that they become so involved in a fantasy or daydream that it feels as though it were really happening to them. Question 22. Some people find that in one situation, they may act so differently compared to another situation that they feel almost as if they were two different people. Question 11. Some people have the experience of looking in a mirror and not recognizing themselves. Question 27. Some people sometimes find that they hear voices inside their head which tell them to do things or comment on things that they are doing. Question 6. Some people sometimes have the experience of feeling that their body does not seem to belong to them. I would argue that many of these experiences are common to all plural systems, and even some are common if you're transgender. Does this make the experiences listed in the DES dissociative? If we go back to what I talked about earlier, there is a feedback loop of stigmatization within DID research. Researchers only look for systems with high levels of dissociation. Researchers find those systems and assess them, and then researchers conclude that their alters are, quote-unquote, dissociated self-states. This feedback loop causes DID specialists to ignore commonalities between DID and non-disordered systems, resulting in skewed tests such as the DES. Common plural experiences are being wrongfully labeled as dissociative, and therefore disordered. Since therapists refuse to listen to the lived experiences of systems, headmates are deemed to be dissociated self-states. It isn't empirical to apply theories to subjective non-physical things, including the human mind. But psychologists go one step further. Within a clinical, singlet-centric framework, any switching that may occur is deemed as a way of protecting the individual from their own trauma memories. And it is deemed as maladaptive, dissociative, and a coping mechanism. Instead of considering the experiences of all systems, disordered or not, our experiences with switching are being categorized as disordered. Is switching really a form of maladaptive dissociation? Or is it the act of giving control to another person within your body? It depends on whether you are willing to interpret your experiences within clinical definitions or within subjective experiences of plurality. If we value our own experiences, then we must believe that switching really is occurring, and that it is not just a delusional effect of dissociation. Let's follow this path to its logical outcome. For example, if we choose to take the clinical perspective of switching and dissociation, then I cannot trust any of my own experiences and perceptions. I would have to believe that all of my headmates are just dissociated self-states, coping mechanisms resulting from past traumas. If we expand this to our other subjective experiences, then it invalidates much of the way I understand myself. I would have to doubt my non-binary gender, my sexual orientation, and even my past experiences of trauma, since all of these things are my own subjective experiences. Who do I trust then? Do I ask my best friend about who I am? Do I appeal to a medical authority? When looked at from this perspective, it's absurd to disbelieve my own experiences. I can't convince myself into believing that my headmates aren't people, and I can't convince myself that my other subjective experiences, including my gender and sexuality, aren't real. If I do, my entire world falls apart. Another large and obvious problem with upholding an objective clinical model is that we are giving our power away, our power to define and describe what we experience. We are trusting that Singlet therapists and professionals fully understand us, more than we understand ourselves and our systems. As a child, I was abused, neglected, and invalidated. Invalidation causes a loss of self-definition and empowerment. Disbelief of your own subjective experiences does not promote the reprocessing of trauma, nor does it support the regaining of one's own identity and power, power which was lost during traumatic events not within our control. And yet, we trust therapists who often treat us the same way as our abusers. We believe they have all the answers. We trust therapists enough to seek help from them, or we are desperate enough that not seeking help is worse. Either way, therapists often invalidate our experiences. More often than not, this happens behind closed doors. It's quite disturbing to see this behavior exhibited by therapists, who we are encouraged to trust with our innermost experiences. As I stated before, the ISSTD, which is an authority on DID, dismisses our lived experiences, instead substituting a clinical model, affirming the idea that therapists know better. I'll read a pertinent quote from Colin A. Ross, who is another DID expert. Quote, "Treatment will be a collaboration but not democratic. The patient is the patient, and I am the doctor. We are not friends, and I am the only one getting paid." Ross, 1997. Ross has also stated that it's okay to coercively drug systems with DID. Quote, "Sodium amytal should be considered when other techniques have failed or when temporary access to an unavailable alter is required. It is a battering ram. It gets you into the system." Ross, 1997. He has even gone as far as to compare us to, quote, "misbehaving children." I think it's time to begin reconsidering whether psychiatry has our best interests in mind. They may help us, but often they do much harm in the process. And they definitely do not understand plurality or what it is like to be a system. They are merely observing from far away, describing a distant island that they can never visit. I think they need to stop assuming and really listen to what systems have to say. They may have studied for years in university, but we have years of life experience being plural. Hi, I'm Lily, and I'm Hyacinth's co-presenter, and I'm a member of the Sapphic Bouquet. And I want to focus on common plural specific experiences of dissociation. When severe forms of dissociation are experienced by singletons, they often take the form of identity alteration. Types of identity alteration include dissociative amnesia and dissociative fugue. These disorders are generalized to plural experiences of dissociation. Psychiatry doesn't think there's a difference between plural experiences of dissociation and singlet experiences. But I think this is wrong. since this would mean that headmates are merely a form of identity alteration. I don't think it's fair or rational to generalize singlet experiences of identity alteration with plural experiences of dissociation, especially because it leads to the misconception that headmates are dissociative parts and not people. Along with this misconception is another, that dissociative parts should integrate so that a system can become a singlet. These beliefs are singlet-centric and inherently anti-plural, and it's important to know that since it can cause a lot of bad feelings for systems, like guilt, shame, and feelings of isolation. I think we should be looking into plural experiences of dissociation so we can really figure all of this out. I think that the idea that plurality is abnormal or maladaptive is almost always strongly rooted in singlet ideas of what is normal, especially singlet beliefs within psychiatry. I want to talk about plural experiences of dissociation from a perspective that does not assume that identity alteration is the cause of plurality. It is not at all useful or beneficial to apply a singlet understanding of dissociation to plural collectives. Now, Hyacinth has already gone into depth about defining what dissociation is. It's a coping mechanism which can sometimes cause harm. Psychologists typically focus on the harm and choose to ignore the positive experiences and usefulness of dissociation. Psychologists are in the business of treating mental illness. Mentally ill people are viewed as having an inferior understanding of the world and their own experiences, so therapists don't often see patients' experiences as useful or reliable. After all, a mechanic doesn't ask the car what it thinks about being fixed. The same mentality is echoed by therapists and professionals, and this can often make clinicians ignorant to certain aspects of disordered dissociation, and especially ignorant to healthy forms of dissociation. Here's a quote from Gail Hornstein, who is a phenomenologist. She talks about how professionals often ignore the experiences of psychiatric clients. Quote, health professionals see the manuals describing real categories of psychiatric illness. I think that feminists and other critics of the DSM would be better off learning what people actually find helpful in understanding and coping with their problems, rather than participating in the ultimately sterile exercise of arguing about categories that turn out to have little relation to anyone's actual experience. Some researchers choose to listen to the experience of people who have neurodiverse experiences. Some of these experiences overlap into mental illness. There are researchers like Paul F. Dell who gathered data on the experiences of DID systems and compiled them. Making a list of common experiences, Dell tried to get psychological authorities like the ISSTD and the DSM to acknowledge his work. Of course, he had to present DID systems experiences as symptoms, despite the fact that these systems were describing their own experiences, and Dell was recording them. Dell was not in fact recording symptoms, since symptoms are the observations of the doctor, not the experiences of the patient. It's unfortunate that the ISSTD didn't see value in Dell's catalog of the experiences of DID systems. Dell's study was done back in 2011 and still has not been implemented into the understanding and treatment of systems with DID. Another psychologist named Kimbra Clayton wrote a paper called Critiquing the Requirement of Oneness over Multiplicity, in which she explores various papers written by DID specialists. She criticizes professionals' assumptions that being a singlet is more healthy than being plural. Clayton shows specific examples of where clinicians are lying to clients and manipulating them into final fusion. Neither of these academic papers have become popular among DID specialists, and we have not seen papers investigating whether dissociation can be more beneficial than harmful. As we've already talked about, dissociation is commonly believed to be caused by stress. This can be normal everyday stress or a traumatic situation. Research on dissociation does not account for natural dissociation. Some people who have chronic pain dissociate. Others with sensory issues dissociate to blur out external stimuli. and I think it's possible that many systems naturally dissociate. Regardless, I don't think that dissociation is a great word for what these experiences are. For one, the word dissociation is so broad. It includes many experiences which are different depending on the context, some of which shouldn't be placed under the label of dissociation at all. Perhaps it's better to talk about natural dissociation as trance states, since it isn't within a pathological framework. Plus, many types of trance states exist. It's also a common experience for most people, and almost anyone can achieve a trance state. Within this understanding of trance states, they are alterations of consciousness and not dissociations of self. If you've ever felt like you're in the flow when you're working, that's a trance state. If you've ever felt like time went really fast when you were busy doing something, that's also a trance state. Ever felt like the world was falling out from under you when something stressful happens? That's a trance state. Determining what is and isn't a trance state is up to the subjective experience of the person. I can look in the mirror and feel like I don't recognize who's looking back. Is that automatically a trance state? No. Have we been in a trance state and felt like that? Well, yeah. But sometimes when I look in the mirror, I just don't feel like I'm looking at myself. Instead, I'm looking at a body that our collective shares, which is not what I identify with. This brings up a pretty big problem with tools like the DES. It doesn't differentiate between non-disordered trance states and disordered trance states. The DES also uses subjective descriptions of trance states. These descriptions could be confused for other related experiences. For example, here's a quote from the DES. Quote, "Some people have the experience of looking in a mirror and not recognizing themselves." The issue with this question is that a transgender person might disagree with this. Does that mean that trans people are dissociating? Hypothetically speaking, I could write a whole theory about dissociation and being trans. I could claim that gender dysphoria is a form of identity alteration, which was caused by dissociation. So the treatment is the integration of male and female aspects of the self. But of course, it isn't based on valid scientific research. It's all just armchair theories. This is just like the armchair theories that professionals use to describe dissociative identity disorder, which is something they don't experience themselves. They only research it. It's crucial for me to say that personal experience is important. When we are making theories, it is very, very useful to have experience with something. Otherwise, we are talking about things we know almost nothing about, aside from a few things we may have read online. So, the trans dissociation mirror theory could actually be the other way around. Maybe looking into a mirror causes a trance state, making a trans person feel disconnected from their body. I personally feel that this resonates more with my experiences of being a trans woman, which gives the theory more weight than the one made by our theoretical psychologists. You could say that I'm setting up a straw man argument, but it's true that psychologists really have done things like this, especially with plurality. They put questions in the DES, not recognizing they are common experiences for plural systems. Then they assume that these experiences are dissociation. We took the DES and scored 42, which is somewhere between PTSD and dissociation. I'm going to read a few questions from the DES. All of these we scored high on. I think it's likely that the experiences described by these questions are common to many systems. Quote, "Some people sometimes have the experience of feeling as though they are standing next to themselves or watching themselves do something, and they actually see themselves as though they were looking at another person." When we dissociate due to stress, this is very common for us. However, we can have this experience and not be dissociating. We know the difference. When Hyacinth is in front and in control, I am not watching myself. I am watching Hyacinth. The idea that we are parts of one person is willful ignorance on the part of singlets. They experience it as watching oneself, so they assume that we do too. The next DES question is, quote, some people sometimes find that they become so involved in a fantasy or daydream that it feels as though it were really happening to them. To our collective, headspace is subjectively real, and the more we concentrate on it, the more real it becomes. Does this make headspace a fantasy or a daydream? I don't think so. It's an internal subjective reality, and having a headspace, whether consciously created or not, is definitely a plural experience. Now, not all plural systems experience this, but many do. So this question doesn't fit well under dissociation, though I think some people do experience this as a trance state. I can't see how daydreaming would be harmful, though. It's a relatively normal experience. Next question. Quote, some people find that in one situation, they may act so differently compared to another situation that they feel almost as if they were two different people. This is basically a description of what it is like to be plural, only it's written by a singlet. Next question. Quote, some people have the experience of looking in a mirror and not recognizing themselves. Well, of course, our system is trans, but we are plural, so we all have different self-images. Categorizing plural systems' bodies as themselves is a singlet-centric view. Not only that, but it ignores trans experiences. Many trans people would say that they feel like they don't recognize themselves when they look in the mirror. That doesn't mean they're dissociating. Next question. Quote, some people sometimes find that they hear voices inside their head which tell them to do things or comment on things that they are doing. This is another common plural experience, but even voice hearers have this experience, even though they are not plural. I don't feel like it's useful to categorize hearing voices as a dissociative experience. This is, after all, the dissociative experiences scale, not the plural experiences scale. Next question. Some people sometimes have the experience of feeling that their body does not seem to belong to them. This is another common experience that transgender people experience, and so do plural systems. Some people who have issues with their body also feel this way. I don't think this is a meaningful entry in the DES. People in trance states can feel this, as well as people who have dissociative disorders. I feel like some experiences that plural systems have could be called dissociative and placed into the category of maladaptive. But some of these experiences are not at all dissociative. And I think it's hard for professionals to determine that when most of them have never experienced dissociation. There seems to be a difference between trance states and dissociation, despite the fact that professionals generally don't recognize the two as distinct. Many of the experiences listed in the DES can be normal and not distressing. Some of the descriptions fall under several categories at once. It's not so simple to categorize these statements as definitely dissociative. The dissociation which plural systems commonly experience is likely just trance states. Many of these things are not distressing to healthy systems, so there is no point using arbitrary descriptions of subjective experiences to label someone as dissociative. Many of the questions in the DES describe things that are trance states. Some systems do experience dissociation, and I think that the difference between trance states and dissociation is meaningful. It's just that psychologists just can't seem to tell the two apart. So if we are dealing in the two camps, trance states and dissociation, then where is the difference? There appears to be some overlap between the two. How do we tell them apart? I think the difference is that trance states are not distressing. Trance states do not interfere with functioning to the degree that dissociation does. Since dissociation and trance states are so alike, I find it highly likely that dissociation is a type of recurring and distressing trance state. The term trance states is then an umbrella term, which dissociation fits under, similar to how hypnotic trance states fall under the broad category of trance states, and the same goes for meditative trance states. How do trance states relate to both DID and non-DID systems? It becomes clear when we look into cooperation and co-consciousness, as well as switching. From our experiences with switching, we know that we experience a light trance state before switching. It's a state where neither person entering front or the person leaving front are there, a between state. The front becomes empty. So when someone enters the front, we exit the trance state, and the switch is complete. During this process, we've never lost memory or time or had a blackout. Sometimes things are fuzzy afterwards, but it's only for a little bit. From what we've heard of disordered systems, most have time lost during triggered switches, which are commonly caused by external things, generally trauma-related things. Sometimes angry headmates can also cause time loss when they switch in forcefully. We've heard disordered systems say that controlled switches don't cause memory loss. When both people switching are aware and consenting, everything is much more smooth. They enter a trance state and then switch. This is the reason why it's possible for DID systems to treat their dissociation through cooperation and communication. This similarity between types of systems confirms that non-DID systems are more similar to DID systems than professionals might like to believe. It would also seem that the trance states that people experience regularly are not the same as dissociation. Trance states help plural systems switch and communicate, and trance states that singlets experience when they're overwhelmed aren't necessarily dissociation. I think there is a meaningful difference between trance states and dissociation. So is dissociation always maladaptive? Within the understanding that dissociation is a maladaptive trance state, yes, then dissociation is always maladaptive, but only if we are viewing the term dissociation as it was originally intended, within clinical or pathological model. Within this plural unified perspective, the validity of systems and their headmates is never in question. Disordered and healthy systems share common experiences related to trance states. This makes it unnecessary to view traumagenic systems as on a different experience spectrum than endogenic systems. Systems are systems, regardless of origins, even if some systems experience dissociation and some don't. I'll introduce Hyacinth's earlier points to sum this whole thing up. So we know that, despite the treatment of dissociation, the vast majority of systems do not experience spontaneous final fusion, and only 12 to 25% of DID systems in treatment achieve final fusion. This contradicts Singlet psychologist theories of DID. Hyacinth quoted many accounts of therapists who said that final fusion of headmates is not an easy process and may result in the fully integrated or fused system being worse off than before. Kloof described this as single personality disorder. We believe that helping systems treat their dissociation and achieve cooperation in their system is more beneficial than final fusion, especially with the realization that all systems experience normal trance states. Some systems return to being plural after having achieved full integration. However, co-consciousness, communication, and the treatment of dissociative issues are all very important to the well-being of systems diagnosed with DID or OSDD. And according to one study, therapy aids greatly in these goals. Psychologists should be reconsidering that cooperation within a system is more important than final fusion. Cooperation is shown to promote health, while final fusion can destabilize the mental health of a system. In conclusion, dissociation is always maladaptive. Trance states that are not dissociative are healthy. These trance states are commonly experienced by traumagenic and non-traumagenic systems. They are also experienced by systems who have DID. Trance states can benefit people who have chronic pain or people who go through traumatic events. Dissociation is what happens when trance states become harmful. They intrude on everyday life and inhibit functioning to a distressing degree. Unfortunately, it appears that most professionals do not distinguish between trance states and dissociation. It's time for psychology to reevaluate that based on a plural understanding of trance states, an understanding which will allow professionals to write better papers and tools to determine when the trance states a person experiences are dissociative or maladaptive. I think we covered a lot in this presentation. We hope to contribute more to the plural movement by talking about our experiences being plural, and by critiquing the psychiatric system. If you have any questions, concerns, or criticisms, or if you think that this presentation was good, then let us know at multi_sapphire on Twitter.